Hi, welcome to the Addiction Recovery Place podcast, the podcast champion addiction treatment professionals around the world. I'm your host, Chris Langley, and I'm very pleased to introduce today's guest, Emily Levine, founder of Levine Consulting, located in California. Emily provides group therapy, compliance, and clinical training to healthcare facilities. She also offers free in-person and virtual assessment-based consultations for treatment referrals to families and individuals seeking behavioral healthcare. Welcome to Addiction Recovery Place podcast, Emily. It's great to have you with us today.
Good to be here. Thank you so much for having me.
No, we really appreciate your time. And I know you're incredibly busy with doing the amazing work that you do. So we're just going to get crack on and ask you some of these questions. So can you tell our audience about you and how you started your consulting company in California?
Yeah, sure. I have been a clinician in the behavioral healthcare space in California, specifically for, since 2016, 2017.
Mhm.
And I come from a background of addiction and mental health.
Mhm.
So I didn't have any job experience prior to getting sober myself. Little jobs here and there like Starbucks or a pizza place, but nothing of significance.
Mm.
And I knew that I wanted to help people in some capacity. I grew up especially with my father, who was a pastor and a helper for his entire life. That was just part of what I knew that I wanted to do. So, Levine Consulting actually came recently at the end of 2023, and it was born from extreme compassion fatigue and burnout and a frustration with not being able to find occupational freedom in my roles anymore. And I quit my job of 5 years and had no idea what I was going to do. I just knew that I wanted to do something different.
Mhm.
And Levine Consulting was kind of a wild hair in the middle of the night where I'm like, oh, you know what? I should start my own consulting company and I'll figure out the rest later. But this is what I want to do. I want to work for myself
Mhm.
for the first time.
Mhm.
And that's how I got started. I keep saying now Levine Consulting is about providing program development, clinical training, obviously accreditation, survey prep for Joint Commission,
Mhm.
the state of California, um, just so much stuff mixed in with the packaging of consulting. But I knew that I wanted it to be person-centered,
Mhm.
and I knew that that was what our field needed.
Yeah.
And I needed to find a way to always have any service that I do come back to, is this going to be client-centered? Is this going to enhance the client experience? And are we truly going to be helping them?
Mhm.
Or is this simply about checking boxes off um,
Mhm.
standards and regulations, which is not what it's about.
Mhm.
So family education, consulting, group facilitation, per diem case management, there's just a lot of stuff in there that I do.
Yeah, definitely. Well, firstly, congratulations on what you've achieved. So
Thank
you've
you.
achieved this in such a short space of time, and your clear commitment to your clients is very, very telling. And the fact that you came from a history of addiction yourself, and you've overcome that, and you're now running your own business, you're now doing your own consultancy. You're working for yourself. I mean, that's incredible. So, congratulations again. So,
Thank you. Thank you.
you've already kind of gone into a little bit of a description, but what makes your consulting company different from other consulting companies? You said person centered, which is very important. But what are the
Yes.
other kind of caveats
Yes.
to that?
So I believe what sets me apart from other consultants is the level of investment that I have in the clinical program.
Mm.
A lot of the consultant companies nowadays, especially in California, it's all about turnkey consulting. So it's all about give me all of the information on your facility and let me fill out all the paperwork and submit everything without any real investment into what is actually going to happen after you get approved or accredited.
Mm.
And that is what I focus on is I care more about what is going to happen after than this whole process of filling out paperwork and submitting applications and stuff. That stuff is easy.
Mm.
It's the second part that
Yeah.
matters. And the problem with being a part of the turnkey kind of model of consulting is they contribute to the problem.
Mm.
The problem exists in that person-centered care must be at the forefront, in order to have incredible outcome measures, in order to impact our clients positively, our families positively. So
Mhm.
it's incredibly important. And I also think the learning environment that I cultivate is entirely different.
Mhm.
Like I said, a huge emphasis on each consulting package is the learning component and the education component. I want to spend a great deal of time investing in an individual and a clinician or a leader
Mhm.
in order to ensure that the clients that come in there afterwards are going to be well taken care of and they're going to be well informed
Mhm.
by their leaders or by the clinicians around them.
Mhm.
So the learning environment, the person-centered care, and the degree of investment that I have into the outcome measures after.
Yep.
And, part of the training, it's spending purposeful time with a clinician and being able to come up with a performance improvement plan using emotional
Yes.
awareness. And sure, I can come in and kind of have these didactic lessons that I teach and spiel at you and hope that you retain the information and then leave.
Mm.
But that isn't impactful to the clinician and therefore is not impactful to the client. So, creating performance improvement plans, if it's a facility that's established, or coming up with a curriculum of training that I can go through in sequence of importance and in sequence of, okay, now we understand this competency. Let's move ahead and go on to acculturation, or let's
Mm.
move into personality disorders. What
Mm.
are some of the things that we're going to see when we open the doors?
Mm.
So it just depends on the facility, but definitely purposeful time is incredibly important and utilizing evidence-based practices in those trainings.
Mm.
And, um, especially for the facilities that are established already, being able to provide a space for a clinician to debrief is also incredibly
Yep.
important.
Mm.
um, Staying tethered to them and making sure that we make time for that in the beginning of our trainings. Like, what's going on? How are you guys feeling
Mm.
emotionally, spiritually,
Mhm.
physically?
Mhm.
Are we doing okay? Are we experiencing compassion fatigue? Because that's the full stop right
Yeah.
there. When we're burnt
Yeah.
out, we can't move ahead. We can't move forward. We're stuck.
Mhm.
So always keeping an ear out for compassion fatigue and burnout is incredibly important.
Mm.
And I honestly, yes, it's a consultant company, and yes, I am a consultant, but teaching is what I love to do.
Mm.
Teaching is what brings me joy and fulfillment. So I do think, it's going back to the last question of what sets me apart. I believe I'm a teacher,
Yeah.
and I love that. I lean into any time I can teach a concept, and I learn in that too.
Mm.
I'm constantly evolving and learning what our field needs and what our clients need, and yeah, it's
Mm.
incredible.
Yeah. Well, wow. This just sounds absolutely wonderful what you're doing and what you've achieved
Oh,
so
thank you.
far. It really does. So, can you tell us a little bit about the programs that you offer specifically? What are some of the programs that you specialize in?
Sure. So speaking to the consulting
Mhm.
first, I only deal with right now at the time subacute, adult,
Mm.
substance use and mental health, residential, and detox facilities.
Mhm.
I'm hoping to open up PHP and IOP at the end of this year. I'm aware of the standards and the regulations for that as well, but
Mm.
I'm focusing right now on inpatient. That's
Mm.
really my space right now, what I love to do.
Yeah.
I have goals of expanding to national and expanding to adolescent facilities and stuff
Wow.
like that, but that stuff takes time,
Mhm.
and I wanna really make sure that I'm very well informed and educated on what I need to do moving forward. So,
Mhm.
adult, residential, and behavioral health, mental health, and addiction.
Yeah.
And, part of the consulting is it just depends on the facility's needs. So if we are in a survey prep,
Mm.
space where a facility is already established and they need help with their either upcoming state survey or their joint commission survey, or they're certified and licensed with the state and they want to start JCO,
Yeah.
those packages depend on what they need. So survey prep or accreditation or licensing. And clinical training is always mixed in there somewhere. I have a separate package for leadership development that is a part of consulting. I love incorporating that when I can.
Mhm.
But again, utilizing emotional awareness in leadership is so important in this field. And it's so important for a number of reasons. And the impact is severe when we see it, such as increased, staff turnover or employee satisfaction, burnout,
Mm.
right?
Mm.
Those are severe consequences.
Yeah.
The reward is just amazing on the other side of that coin as well.
Mm.
And then quality control is built into each one of those. So auditing, staff training, obviously
Mm.
support staff clinician training,
Mhm.
um, they need help recruiting, things like that. So I try to fit in as much as I can in that space for what I can prioritize and take over.
Yeah.
And family education is something that's incredibly special to me.
Yes.
Family groups and a family weekend can absolutely change the trajectory of a client's future
Mm.
and their family's lives.
Mhm.
And so that is what the family education component is for, is just to provide resources to educate and to support. And if they need placement or if they need help finding placement, I use an assessment based portion similar to what treatment centers use.
Yeah.
But mine's specifically tailored to what I think is really important that I need to know about the client, strengths, preferences, needs, um, presenting issues, obviously.
Mhm.
And we come up with a plan together of here are some resources or places that I think would be a good fit for your child or for your loved one. And we go from there. I consult with a lot of different professionals in that process.
Mhm.
So I'll reach out to people that I'm very comfortable with that are clinicians in the field to get to make sure that I'm making the best
Mm.
informed recommendation that I can.
Yeah.
And a lot of those services I also provide for free. So
Oh,
I
wow.
typically do not charge families for that. Yeah.
Really?
Which
Oh,
is
wow.
special. It's
Yeah.
special to
Yeah,
me.
of
Yes, it's
course.
very
Of
special.
course. Of course. Yeah.
Um, Per diem case management and group facilitation are the other two things that I do that I will always remain tethered to in some way, shape, or form. I've since recovering from the burnout that I experienced for about upwards of 2 years at the end of working in a
Mm.
facility. Um, I will never let that part go again.
Mm.
I think that's what happened. I think that contributed to me losing the passion and
Yeah.
the fever that I needed to feel. And so per diem case management is a great way for me to do that. It's a way for me to remain engaged with the client, always keeping up on evidence-based practices and coping
Yeah.
skills. And a lot of the interventions that we use in session are things that I continue to learn and grow upon. So per diem case management typically provided to facilities where I will do groups or they contact me directly for a case manager that
Mm.
can come in and do a mixture of both,
Okay.
and then groups as well. Group facilitation
Mm.
is special.
Mhm.
Yeah.
So how do you get your referrals? Do you get them people just calling you, or do how do you get referrals, and how are you promoting what you're doing? Because it's some amazing work.
Sure. Sure. So I actually have not ever promoted myself anywhere.
Mhm.
So, and I'm looking into doing that this year. It's something I obviously want to do. I want to cultivate some content that's education
Yeah.
based and do all those things. But
Mm.
in terms of putting myself out there and going, hey, my name's Emily Levine and here's Levine Consulting, I have yet
Mm.
to do that. And I think that I'm not sure there's any specific reason for that. I think it's just I've been blessed with knowing so many people that I love and respect in this field
Mm.
that word of mouth and recommendations
Mm.
have just been what has kept me afloat and successful.
Mhm.
Um, and I don't work specifically. I do think this part is important though. I do not work specifically. I'm not affiliated with any provider or agency or any form of networking referral network.
Yeah.
And I think that that's important to maintain
Mhm.
um, because we see all the time, especially in California, that recommendations or interpretation can be skewed when we are responsible to someone or something.
Mm.
So I want to remain completely independent. I want to be able to make informed and educated decisions based on my belief of their clinical
Yeah.
program and not my personal relationships within that program.
Mhm.
So yeah,
Wow.
it's been incredible, organic,
Very
completely.
organic, absolutely. If you've not done any marketing or any, you have a great website, and I
Thank
was
you.
reading the testimonials, and it's just incredible what people feel about you and your expertise and your experience and what you bring to people. It really is.
Oh, thank you so
I would,
much. Every one of those individuals are so special
yeah,
to me.
I, I,
Incredible people in the field.
I would strongly suggest anyone listening to this podcast to go and look at Emily's website and just read the reviews. It really did. It really was very impressive, and I'm very grateful to having you on the podcast, because what you're doing is very unique as well, and it's something you've done yourself, and you've not had any other support. I mean, you've gone through extensive work experience. You've grown. You've developed this consulting business, real value. I mean,
Oh,
you're
thank you.
working with families, you're working with therapists, you're working with groups, you're working with businesses. Um, One of the specialities is clinical and staff training, Emily. Can you
Yeah,
tell us about this and who do you work with for that? Because that's very specific, especially on staff training.
sure. So a lot of the time, at least thus far, I've done all my clinical training or a majority of it with facilities that I'm already affiliated with,
Yep.
either consulting or doing groups for,
Hmm.
or we just create a relationship and they need help. And I'm like, well, I'm here to help you if you need help. So um, in terms of a training environment for a clinician, it's largely scenario based. When I cultivate some sort of curriculum or the environment is scenario based. I utilize various learning materials, so that can look like a PowerPoint or SAMHSA has some great materials on learning. NADAC has some incredible resources for clinicians to learn. So we culminate together. It's very collaborative.
Mm-hmm.
It's again, it's person centered to the clinician as well.
Mm-hmm.
It's me spending some time building rapport with them and helping them uh, be able to recognize problem areas of their own, which is a challenge in itself because not everyone is understands or is prepared to admit where faults
Yeah.
are or weaknesses
Mm-hmm.
are. And so there's a very supportive and creative way it's really important for me to be able to communicate that to them in a very supportive and compassionate way. And I constantly relate it back to, oh, I remember this one time where I really messed up. Let me tell you about it.
Mm-hmm.
Constantly referencing mistakes that I've made or places where I've grown because it's really important that the learning environment remain consistent whether I'm there or not. I hope that it persists even when I'm gone and when training is over, where they get to then pass on what they know to the next clinician and so on. So largely scenario based.
Yep.
It depends on, again, the clinician, if they prefer video learning, if they're kinetic, if they're auditory learners. So I use that in my teaching as well and try to be mindful and cognizant of that. And there's a large emphasis on critical thinking and problem solving when it comes to assessing, is this decision or is this behavior or model going to impact the client in a positive way? Or is there a better option?
Mm-hmm.
So again, we constantly reference back to person-centered care in all of our learning and formulate multiple scenarios and multiple solutions to each problem so they can factor in the variables that we know exist in behavioral health care each day, all the time.
Mm-hmm.
I also utilize trauma-informed practice, so I am trauma-informed. I like my clinicians to understand what that means and to be able to employ those practices in their care of a client or in their program development period. Um, and again, just increasing their understanding of person-centered care and the overall client experience and also the family's experience, right? Because
Yep.
families need to be a part of this
Yes.
if a client is open and willing.
Mm-hmm.
So we do family systems training. We do emotional intelligence training, right? Being able to read a client, interpret a client. It's so fun, Chris. It's awesome. It's my favorite part.
I love it.
I probably shouldn't say that, being that the consulting is the first thing on my website, but training and teaching
Yeah.
is the
Yeah.
best. It's the best part
Yeah.
because again, I continue to learn. I
Yeah.
continue to get better.
Yeah. I
Yeah.
can just hear the passion and love you have for your work and for helping your
Mhm.
clients. It's truly humbling to hear what you're speaking about and what you're doing, Emily. It really is.
Thank you.
Um, you mentioned NADAC. Obviously, we met on the NADAC forum, and can you
Yeah.
just tell us a little about how you benefited from being a member of the country's largest association for addiction counselors?
Yeah, NADAC is incredible. One of my goals is to become more involved with NADAC,
Mm.
whether it be at a legislative bill, partisan type of thing,
Mm.
or whether it's a community outreach type of involvement. But I'm relatively a new member of NADAC.
Mhm.
I reached out to NADAC and they have an incredible program where they waive your first year of registration if you are a clinician.
Mhm.
It's kind of like a raffle thing. So I reached out in there when I had just started Living
Mm.
Consulting and I said, hey, I just started my own company. I'm broke right now, but I really want to be a part of NADAC. I really want to
Mhm.
understand what this is and be able to have access to all these resources because I need to grow
Mm.
and I need to continue to be learning
Wow.
and educating myself so that I'm, again, passing on the correct information.
Mhm.
So NADAC for me has just been a reservoir of education material
Mhm.
for me.
Mhm.
I have leaned into their leaned into their webinars on cultural humility. They have so much
Mhm.
stuff on different topics that we deal with in behavioral healthcare,
Mhm.
clinical supervision being one of
Yeah.
them. So they have been an incredible resource for me to learn.
Mm.
It's a resource that I trust.
Yes.
They use a lot of evidence-based tools. They have incredible clinicians with multiple letters behind their
Mhm.
name teaching a lot of these webinars. So that's something that has been incredibly useful
Mhm. Yeah.
for me
Yeah.
specifically. So
Oh,
yeah,
well, thank you for that. I wanted to mention NADAC, obviously, because that's where we first met, and I feel exactly the same way that you do about the organisation. It really is
yeah,
a great resource for everyone, really.
yeah.
We're kind of moving on a little bit, kind of around what's kind of going on in California briefly, Emily, because when we first
Mhm.
met, you mentioned some rather shady ways that agencies or insurance companies are using people suffering from addiction to make fraudulent claims. I think you mentioned this is called body brokers. Is that right? I'm kind
Yes.
of unfamiliar with this practice. So, can you explain in a little bit of detail about how this is affecting client care and the obvious aftermath of people not being able to access proper treatment?
Yes. Body brokering has run rampant in Southern California.
Mm,
For whatever reason, our insurance companies and carriers and the way that they provide behavioral health care services in California specifically, and a couple other states,
mm,
um, are not regulated to the degree that they should be.
mhm,
So body brokering can exist when a intermediary is working specifically with a facility and then gets paid per head, we say, or per client
right.
for each client that lands in their facility.
Okay.
So again, obliterates person-centered
Mhm,
care and completely obliterates informed consent on the patient's part.
mhm,
But the problem with this exists in that the referrer or the marketer, broker,
mhm,
then gets paid for that. And we saw it happen where the marketer would get paid and then the client would get paid from the marketer as enticement to go to treatment, which you can imagine the repercussions of paying a client to go to treatment for a set period of time.
mhm,
The the
mm,
treatment hopping,
mhm.
cycling back and forth through treatment, the relapse
Yeah,
rate skyrocketed.
can imagine.
So
Yeah.
those are some of the issues. We also see body brokering or unethical behaviors happening where in UA urine analysis
Mm,
systems as well, which is probably a whole separate conversation.
mm,
But
mhm,
um, in terms of the level of deceitfulness, I do think it's important that when we talk about body brokering, we have things in place to sort of to sort of uh, push people away from it. However, they're not being implemented. So
mm,
I believe it was in September 2018, the Senate Bill 1228 was approved by Governor Brown, and this was specifically enacted to combat patient brokering,
right.
which is what it's referred to.
Okay.
And because of that bill, there were extra sections added into the California Health and Safety Code,
Mm,
which is another regulation that behavioral health care facilities, at least subacute, need to abide by.
mm,
Um, the problem with this is there is no set penalty that is stated in the bill that the state can enact upon someone.
okay.
So it's just, hey, you have the freedom to penalize someone for this behavior.
Right.
We're not going to tell you what you can do or can't do,
Mm,
and we're not going to tell you how to do it. And we're going to assume that you have the infrastructure to be able to do that, but the state does not. We do not have the infrastructure to assign analysts
mm,
and investigators to be able to investigate these types of
mm,
claims. Um, the other problem is if they do happen to investigate and they visit a facility, which looks like a state visit, right?
mhm,
And they come in, the degree of deceitfulness, uh, there is no promise that that investigator will find that it's happening because it's very well covered up
okay.
by marketing tools, marketing materials, marketing payments, right?
Wow.
So it's very well covered up by the provider and the company.
Mhm,
Um, the other penalization that they talk about in the bill is you can have your license revoked,
mm,
right? So we're talking about a certification or a license on the state's end, or we're talking about a counselor's or a certified individual's license being revoked on that part.
Mm.
Well, the problem is the brokers are not licensed or credentialed. We're talking about uh, we're talking about unprofessional, non-credentialed, paraprofessional is not even the right term to describe it. We're just talking about people and often clients. Often clients come into treatment, they get exposed to this
Yeah.
unethical
Yeah.
behavior, and then they
Yeah.
go out and they start marketing a facility to clients, being a client themselves.
Gosh.
So we've seen it all the time. We've seen it all through Southern California and stuff. So there is no direct remedy for it. In terms of it affecting in terms of its impacts
Mm.
in behavioral healthcare, they're severe.
Mhm. Yeah.
We're talking about incredible relapse rates
Mm.
at an incredible high.
Mhm.
There is often sexual abuse and inappropriate relationships happening between the female or the male
Yeah.
clients and these brokers or marketers, right?
Yeah.
We're talking about an increase in homelessness.
Mm.
When you are hopping between facility with hopes that you're going to get covered and paid and you're not, right? You will have nowhere to go. Families are caught in the crossfire of this, right? There's no family integration happening in treatment
Mm.
because the facility is afraid that the family will find out what's going on. So they just don't incorporate them at all. Frequent HIPAA and
Yes.
42 CFR
Mm.
violations.
Mhm.
Um, and at the end of the day, just very little access to resources.
Mm.
Facilities that engage in this type of behavior are not clinically robust facilities.
No.
They're not facilities that employ professionals that know what they're doing, because if they were, the professionals would have
Yeah.
left, right?
Mhm.
Which is often what we see.
Mhm.
It's why pretty much everyone in California has at one point in time worked for a shady facility,
Mm.
right? You just
Mm.
end up
Yeah.
there,
Yeah.
and then you leave.
Yeah.
But
Yep.
in terms of patient-centered care, it's
It's
non-existent.
non-existent. No.
It's absolutely
Yeah.
non-existent. There, especially on the client's part, there's no informed decision-making on the client's
Mhm.
end, which we expect,
Mhm.
right? When they're getting paid to go somewhere, why would you have motivation? There's the treatment readiness is obviously compromised.
Yeah.
The motivation to get sober is compromised. So it's an incredible uphill battle that we continue to face.
Mhm.
And there is no database that you can check and go, okay, is this place ethical? What complaints are out there? What's happening? Because the state is not required to publicly report that. That's not public information. So you have to rely on word of mouth, client
Yeah.
experiences to know who's shady. Or if there happens to be an indictment, which there are a few,
Mm.
then you have obviously access to that information. But it's
Mm.
just, um, it's atrocious.
It's it it
It really
it's
is.
complete fraud. It's complete
Mhm.
it's complete zero care, and it's all about the dollar.
Yeah,
That's it.
yeah,
I've
yeah.
when you mentioned this to me when we first met, Emily, I was trying to get my head around what it was, and you just explained it in such a concise way. And I'm sitting here like I feel angry that
Yeah,
this is even a
yeah,
thing. I mean, my goodness me,
yeah.
this is so risky behavior, and so this can make the addiction problem so much bigger. And so, for
Mhm.
society, for the person, for the families, and family members think they're going in there for treatment, and they come out and they
Sure.
just continue. And wow, that's that.
And the families are like, "What's going
Yeah.
on? I don't understand.
Hmm.
I just sent my child. I live in North Carolina. I just sent my child to California to receive treatment,
Yeah.
and they're homeless
Yeah.
on the
Yeah.
streets,
Hmm.
having not received any help
Hmm.
repeatedly for
Mm.
years." And I've had clients come into facilities that I've worked with and consulted with program director, clinical director, and we have to have an honest conversation and sit down and go, this patient's being brokered. What are we going to do?
Gosh.
I have cussed out brokers before on the phone working at facilities. I mean, I am not, have no qualms with getting vocal with these people on
Mm.
um, how incredibly detrimental they are and continue to be to
Mm.
people,
Mhm.
right?
Mhm.
Forget clients,
Yeah.
they're
Yeah,
people. They're
exactly.
people that are
Yeah.
being essentially trafficked. I think the
Yeah.
other important part to mention with brokering too is a different type of brokering that we've seen an increase in the past few years,
Mm.
where facilities are now employing certain people or employees that work for their program to go to different states and obtain fraudulent insurance policies through then obtaining fraudulent residence documents. So this is one thing that we've seen rise. We've seen a huge escalation in Oklahoma, Blue Cross Blue Shield of Oklahoma.
Right.
There's Alaska policies that you can finagle. New York, I mean, they're all over the
Mm.
place, and they will just go obtain residence documents, right, to prove the client lives there
Right.
with a falsified address, and therefore obtain a state insurance policy that is then covered in California as an out-of-network or in-network
Hmm.
policy. So it's disgusting.
Hmm.
It's unfortunate. It's really unfortunate. And to even further, it's like, how is the state meant to investigate that type of thing,
Mm.
right? We have I think it's insurance section, part of the California insurance code. I think it's 750 that talks about obtaining fraudulent insurance policies. And they state a specific penalty in there.
Mm.
They say, hey, here's the minimum and the maximum amount of time you can spend in jail. Here's the fine. Here's the restitution. But again, it's like we don't have the infrastructure for these people to investigate and then
Hmm.
prosecute something like this. It is a criminal
Hmm.
offense. Their facilities are well aware of that,
Mm.
but there is no infrastructure to stop providers. Okay, I get my license revoked from the state. I can just apply again and get another one under a different company name, which we've seen multiple times. So it's broken.
Wow.
It's very broken. But
Yeah.
while we're spending time talking about body brokering, there are incredible facilities in
Yes.
California
Yes.
that have been around for a long
Hmm.
time. There are people that are just incredible. They've
Hmm.
been doing what they've been doing for so
Hmm.
long, and they've remained and kept their facility
Of
sacred
course.
and
Of
safe.
course.
So
Yeah, oh no, I
yeah,
get you. There's always some bad apples,
with the bad, there's the
as
good.
we say
Yeah.
in the UK. There's always some bad apples, but it's always the good
Yeah.
ones that outshine. And you're an example of this, Emily. There's no question about that. Would you say that homelessness, this whole brokering thing has changed? Because homelessness in California just seems like such a problem on an epic scale. Would you say this is kind of added to this, maybe? Because you were saying people are going from facility to facility, and
Yes.
yeah.
Yes.
Hmm.
I mean, our strain, the strain that's on social services and public health in California already is extremely severe.
Hmm.
But when you add uh, several different non-residents, non-California residents, and bring them into California with no stable living environment, no aftercare planning, no discharge preparation or anything like
Yeah.
that, because of this
Yeah.
behavior, you will then increase homelessness in
Mm.
California. Yes.
Hugely.
And
Mm.
deaths ultimately as well.
Yes. Yeah, because my next question was, I want to just briefly talk about the fentanyl crisis, and there's a real trend, and it seems to be getting bigger and bigger and bigger. So how is California dealing with this crisis, and what needs to be done to ease the pressure on the community at all? Because it just seems to be growing week by week.
Yeah. Yeah. California has done a semi decent
Mm.
job at starting to incorporate some harm reduction prevention strategies.
Good.
We have things like Operation Engage. We have obviously the National Harm Reduction Coalition and things like that that are starting to show themselves a bit more in behavioral health care as well as public health care.
Good.
There was a crazy stat that I read. I believe it was from Facts on Fentanyl, and it said 40% of overdose deaths in California, a bystander is present. So imagine the amount of deaths, which we are in the
Mm.
thousands of deaths per year.
Mhm.
40% of those deaths, a person has been there. So when you talk about being able to make a positive impact on the communities in California because of the fentanyl
Mm.
crisis, you're talking about, which we will get into, harm
Yeah.
reduction, right?
Mhm.
The prevention strategies that we can utilize, making naloxone, increasing the access of naloxone, make it free,
Yeah.
right?
Mhm.
We're talking about naloxone
Yeah.
training. I cannot even tell you. It's honestly the amount of people that do not know how to properly administer naloxone that either work in treatment or don't is astounding. Being able to train and create access of that education and that training to multiple people,
Mhm.
right?
Mhm.
Train in schools,
Yeah.
right?
Mhm.
The days of ignoring drug use and alcohol abuse in schools is over,
Mhm. Yeah.
sadly.
Mhm.
So, there's a number of things that we can do. It's just about increasing awareness, reducing the stigma, and making harm reduction and prevention strategies a bit more accessible. I think would make a great impact.
Definitely, most definitely. So, I ask everyone this. You've spoken about harm reduction, but I always finish my podcast with asking this question, Emily,
Yeah.
because I get many interesting and varied answers. My main background in the UK was very harm reduction focused, and
Mhm.
but can you tell me what your opinion of what harm reduction is and how it plays such a pivotal role in recovery?
Harm reduction is essential.
Yep.
And, harm reduction, again, it's still there's still a stigma around the word
Mm,
or context of harm reduction.
mhm.
And again, those days are over. We're
Yep.
done with that.
Yep.
The amount of deaths and the increase of substance use that we've seen across our country is heartbreaking.
Yeah.
It's heartbreaking,
Mm,
and it's essential and it's critical to behavioral health care. Again, an important part of harm reduction is to being able to assess, is this strategy or is this prevention method going to help my client? And we talk about that in person-centered care. We talk about it in training. Let's assess the person's background, right? Let's assess what is their relapse potential. Let's think about their treatment readiness. Let's think about the positive impact or the pros and cons of introducing a harm reduction strategy to them. Is it going to help them or is it going to hurt them?
mhm.
Right.
Yeah.
So being able to use clinical discernment and interpretation in assessing of harm reduction in individual sessions is critical, but there's nothing to say that we can't educate them no matter what, right?
Mhm.
Being able to explain to them that there are safe places where they can go use, providing Narcan,
Yep.
right? Naloxone training is now finally been, past couple of years, finally been adopted by JCO and the state, that naloxone training is required at least one person per shift. And Narcan must be at the facility, at least 2 boxes of unexpired Narcan, which it's a relatively new addition,
Mhm.
which is kind of wild,
Yeah.
but it is in there.
Mhm.
The newest addition as well is the MAT policy, right?
Mm.
So we're talking about medication assisted
Yep.
treatment, which again is just harm reduction.
Yep.
So there are
Mm,
incredible resources for this. Um, the impacts of utilizing harm reduction strategies are incredible. They're very similar to what we've talked about already.
mm.
We reduce overdose deaths. We increase client awareness, right? We reduce stigma.
Yep.
We prevent spread of infectious diseases. And again, we improve clinical care outcomes, right?
Absolutely.
So if we have a client who's experiencing cravings on a 10 out of 10 for 30 days of treatment, how much work do we really think they're going to get done? Almost none.
Mhm.
They can't think.
Mm,
Their stress, their anxiety. It's so again, just simply utilizing effective harm strategies, right? Putting them on an anti-craving can significantly help that client's treatment engagement
most definitely.
and therefore help them achieve their treatment goals. So there's a lot to harm reduction. There's a ton of stuff out there.
Mm,
I highly, highly recommend, and I understand why clinicians or individuals would be wary of harm reduction.
mm,
But I encourage anyone who's wary of it, just go on to Google Scholar or read some journal publications on harm reduction and make an informed, educated decision at that point if you agree with it or not. But there's incredible data out there to support that it is effective and it is useful and it's actually very, very important.
yeah.
Yeah.
Yeah. Well, that was a perfect description, Emily. It really was. I agree with every single word you
Yeah.
just said. So, last couple of questions, kind of an important one, but do you have a message for anyone listening to this podcast who is going through addiction or suffering with their mental health? What message do you have for anyone?
I'm gonna try not to cry in this question.
Okay.
I
Okay.
when I
Okay.
when I saw it originally, I thought, "Oh my god, what a good question."
Mm,
And I constantly think about it all the time, right?
mm,
Whether it's a graduation ceremony for a client or the first day that they walk in the door, I try to think to the best of my ability, what is the thing that this person needs to hear?
yeah.
Do they need empowerment?
Mhm,
Do they need to be validated in their emotions? Do they need tough love? Do they need a direct approach, right? Which is sometimes we need.
mhm,
But for anyone listening, I hope that my passion and my love for this field and for people comes across strongly because it drives me. It drives my decision making. It drives my belief system.
mhm,
And it most importantly drives my purpose and my intention for not only my career, but my
mhm,
life. And I have suffered tremendously in my
mm,
life through addiction and
mhm,
recovery. There have been some really challenging moments where I just needed support. And so, for anyone listening who suffers from mental health or substance abuse or feels alone, I just want you to know that you're loved. You are so loved. You were made intentionally with purpose and divinity, and you belong here. And I hope that someone can support you. And if not, reach out to me. I'll give you a hug or give you a little conversation on the phone. But I just,
Mhm.
um, showing love, love and clinician and working as a clinician. It's not really talked about a lot. It's kind of like, okay, boundaries, ethics. We can't talk about how we love the client, but I love my
Mhm.
clients. I love every single one of
Yeah.
them. And I have found ways to communicate my love through action, whether that be continuing my education or relying on evidence based practices or introducing more holistic ideas because that's what the client needs.
Mhm.
Um, that's how I show love. So it's incredibly important that as clinicians, we continue to find ways to show love in that way.
Yeah. Most definitely. Emily, you said about people contacting you. Can you tell our listeners how to best to contact you and to find your service online?
Sure. The best way to contact me is to visit my website,
Mhm.
levineconsultingllc.com. You can also reach me at levineconsult@gmail.com,
Yeah.
which is also listed on my website. And Instagram also works. You feel free to send
Yeah.
me a message there. And I try to incorporate a lot of my content to answer a lot of questions
Yeah.
on various different social media platforms. That way,
Mhm.
someone doesn't always have to reach out if they're unsure. They can just read up on some of the common questions or
Yeah.
facts that they have. And uh, but yeah, I hope people can find some solace or comfort or answers on one of those platforms.
I'm sure they will. Emily, it's been a real privilege to have you come onto the podcast, and the work you're doing is exceptional. And everything that you have said, I completely agree with. And it's just lovely to have another amazing professional on the podcast to tell us about the great work that you're doing, because this is what it's all about. It's acknowledging the work that you're doing and to show people the commitment. And you've got that in abundance, and
Oh, thank you.
you really
Thank
do. And
you.
it's just it's a genuine privilege to have you today, and I really really appreciate your time and coming on to talk to me. Thank you very much indeed. And
Thank you so much. What an honor. Thank you so much.
it's been amazing.
Thank you.
Been amazing. Thank you so much, Emily.
Yeah, thank you. Talk soon.